with a 5-year history of poorly controlled hypertension, fatigue and malaise. She is taking different medications including a diuretic and a beta blocker. So can you understand, this is a patient of hypertension, and also remember she is also on diuretics also and a beta blocker. So one thing is clear, a female with a poorly controlled hypertension with multiple, you can say, antihypertensive, this is going more in favor of what, a classical case of the aldosteronoma. Let us try to understand this thing. What is the next best step in establishing the diagnosis, and what should be the correct, you can say, approach now? Now when we are talking about this patient, we have a classical thing. We need to prove that there is hypertension, there is hypokalemia, and there is increased aldosterone level because of a tumor. So CT of the abdomen or the pelvis will tell you maybe about a mass. 24 are fractionated urinary metanephrines. They are for what, students? They are for the classical that we have is pheochromocytoma. Now aldosterone level and plasma renin activity is the gold standard investigation to confirm the aldosterone, and this is what is very important. So aldosterone levels and the renin activity is the only way to confirm this. Yes, now to localize on which side it is, we will be going for the CT or we will be going for the MRI. So this is what is a very simple thing that we have. Let us try to understand few important things about the pheochromocytoma, because pheochromocytoma is again very important. And then we will also have, when I will go to the adrenal part, I will discuss about the approach to aldosterone and the other important masses. So amongst this, I am selecting a topic of pheochromocytoma, which is again very important. Why it is not a pheochromocytoma, why it is aldosteronoma, we have got to see. But when we talk about the concept of pheo, you need to understand this is a tumor of adrenal medulla, and this is what is very important. So it's a tumor of adrenal medulla, and here you are going to have excess of catecholamines. So excess catecholamines are very important thing that will define this, and because of this excess catecholamines, you will have increase in norepinephrine, increase in epinephrine also, and because of this you have all the, you can say, all the symptoms. Let us try to understand them. Let us understand them. So whenever we have a pheo, what is the initial approach to pheo? Try to understand if there is excess of epinephrine and excess of norepinephrine. The first thing that will happen is what, students? There will be the classical complaint of hypertension. Now why is this hypertension a bit different from the others? Because whenever there is increased endocrine activity, there is release of, you can say, hormone from this organ, there will be a surge, and that is why this is not always constantly seen. This is episodic, or you can say paroxysmal. Along with that, increase norepinephrine, increase epinephrine, more sympathetic stimulation, and therefore you have palpitations, you have diaphoresis. So palpitations, we have diaphoresis, and along with that you also have the headache. Now whenever you are thinking about pheo, you always think about going for the plasma or the urine. So plasma versus urine metanephrine activity. I hope you understand that whenever we want to confirm any endocrine related abnormality, it is the urine level of that breakdown of that you can say target molecule breakdown products which is desirable. But here, to confirm anything in the urine level, you will have to prepare this patient. So you will have to give an advice that you will avoid anything which can interact with MAO, B and catechol orthomethyl transferase, that is COMT. So for 1 week you will not be eating these cheese loaded items, these drugs and this and that. So before doing that exercise, try to understand if something is expected to be elevated in urine, it has to be elevated also in the plasma. And therefore whenever you have a suspicion of the pheo, the first line drug, this is what is very important. The first line drug that we have, the answer is I'm saying first line drug, the first line investigation that we have, answer is plasma metanephrines. Do you know that plasma metanephrin is not having any diagnostic significance? However, if the plasma metanephrin is not elevated, in that case it could be anything but not a what students? A FEO. So FEO is ruled out in this case. This is what is again very important. Let us try to understand if plasma metanephrins are found to be what students? If they are found to be elevated. Now this is very interesting. If the plasma metanephrine is elevated, in that case what is the confirmatory investigation? This is what is important. So for confirmation we need to go for what? 24-hour urine metanephrines, and this is what is written in the question also. So 24-hour urine metanephrines, they are the investigation of choice, not the first line investigation. Remember, if 24-hour metanephrines are found to be elevated, so if they are elevated, yes, it will confirm the diagnosis, and if it is not elevated, remember, once the plasma metanephrine is elevated and the urine metanephrines are not elevated, then you will have to do a repeat urine metanephrines, and this is what is very important. If for the second time it is not elevated, in that case only you can say the FEO is ruled out. So the moral of the story is plasma metanephrines, if they are elevated, you need 2 urine metanephrine samples. Now remember, if it is elevated, then the diagnosis of FEO is confirmed. There could be a status when neither it is high nor it is low. So we can say if it is having an equivocal level. So if you talk about the equivocal levels, it may be due to the tumor or it may be due to the hyper alert sympathetic system. So if it is sympathetic system, it is the brain which is controlling this level, and that is why we go for alpha 2 agonist. So when we go for alpha 2 agonist, try to understand these alpha 2 agonist, what are they? We have clonidine. So we have clonidine, and clonidine is going to suppress the brain, and that is why we go for clonidine suppression test. And remember, if the clonidine suppression test is found to be what students? Positive, in that case the FEO is ruled out. Why? Because clonidine will act on the brain, and if it was actually due to increased sympathetic activity of the brain, it will be ruled out, and this is what is very important. Remember, if clonidine suppression is negative, then the diagnosis of FEO is actually confirmed, and this is what is very important. So let us go back to the question paper, and again let us understand this question. The another question that we have is 18-year-old boy presented to the ER with pain which started around the umbilicus and migrated to the right iliac fossa. You know, it's a favorite case of every surgeon. That is, we are thinking now in terms of Meckel's diverticulum, or we can talk about the acute appendicitis. So basically it is acute appendicitis because Meckel's diverticulitis is not that common. Anyways, on examination the patient is febrile and there is tenderness in the right iliac fossa. Which of the following will not be present in the patient? So we are talking about acute appendicitis, and which of the following will not? So pain on right iliac fossa on palpation of the left iliac fossa. So whenever you press the left iliac fossa, there will be pain. Yes, there will be pain, and this is what is known as what sign, students? This is known as Ropsing sign. What happens when you talk about the Ropsing sign? When you press on the left iliac fossa, the viscera is more lateralized, and when viscera is more lateralized, the inflamed appendix comes in contact with the parietus, and that is why you have more specific pain over the right iliac fossa. So this is true, absolutely true. Now pain on internal rotation of the right hip. Now what is this? We have two signs, we have obturator and ilios, or you can say the Schwarz sign. So when we talk about the obturator sign, what is the classical concept of the obturator sign? Let us try to understand. At the level of knee, there is flexion and external rotation. Why? Because when you externally rotate the knee, at the level of hip there is internal rotation, and when there is internal rotation at the level of hip, the obturator nerve comes in contact with the inflamed appendix, and therefore there is pain over the what? The hypogastrium. So this is what is very important, and this is also true. Pain on extension of the hip, pain on extension of the right hip. Students, again, this is nothing but the Swas test. So when we talk about the Swas test, yes, on extension without the knees flex, when you elevate the limbs, there will be pain, and this is a Swas test. So this is also true. Try to understand feeling of emptiness in the right iliac fossa. This is false. Why? This is seen in case of intussusception. So in case of intussusception, like ileocolic intussusception, will have this, else we will not have this. So this is what is very simple thing. Yes, you must have already seen the options. Let us move forward. A diabetic and a chronic smoker presented with dry gangrene of the 3 toes of the left foot and the 2 toes of the right foot. Which of the following will not be seen in this patient? So we are now, we are talking about the peripheral arterial disease, and this patient is also diabetic. This is chronic smoker presenting with dry gangrene of the 3 toes of the left and 2 toes of the right foot. Okay, so forefoot pain on lying down relieved by dangling of the bed. So this is a classical thing that we all know, that whenever the patient is having any complaint of rest pain, and whenever the patient is having the limb, you can say, suspended down, so patient will always have more pooling of the blood and better extraction. So this is one very important rule. So this option is absolutely true. Then ABPI. So when we have ankle brachial pressure index, what is ankle brachial pressure index? It's very simple. It's the ratio of the anterior tibial artery at the level, you can say, the systolic blood pressure of the anterior tibial artery to the brachial artery. Always remember, it will be, normally it is more than 1. Less than 0.9 indicates the peripheral arterial disease. Less than 0.7 increases the risk of intermittent claudication. Less than 0.5 increases the risk of rest pain, and when it is less than 0.3, yes, there is increased risk of, you can say, limb loss. Why? Because this is known as critical limb ischemia. So I would say option B is partially correct. Let us wait for and see the other options, because whenever you are solving MCQ, students, we have to choose the best answer. There could be 2 answers which may be looking like incorrect, or 2 may be looking like correct, so you have to choose the best of them. So pain in calf while walking for the long distances, obviously this is the intermittent claudication. Relief of pain by flexing of back, this is not going to be seen. So relief of pain by flexing of back, this is not a radiculopathy, and that is what is very important. So option 3 here is incorrect. Let us go to the other question. You can always go through the solutions and you can just check it out. So let us understand one more question on the breast. A 31-year-old pregnant lady complained of breast lump in her right breast. So pain, there's a lump in the right breast. It was suspicious on ultrasound and biopsy revealed to be an invasive cancer. The size of the tumor was 6 centimeters. So obviously it is more than 5 centimeters. So it is going to qualify for T3 now. With axillary metastasis, so axillary lymph nodes were present. The patient was currently in the 24th week of POG. So this is a CA breast with pregnancy, and she is keen on BCS. How will you manage this patient? So when we talk about CA breast in pregnancy, you need to understand that radiotherapy is absolutely contraindicated during the pregnancy, because fetal radiations are going to be very hazardous. Second is chemotherapy is contraindicated in at least the first trimester, and again this is what is very important. Since radiotherapy is contraindicated, BCT is also contraindicated. Why? Because BCT is equal to BCS plus sentinel lymph node biopsy plus radiotherapy. If you cannot give radiotherapy, you cannot do the BCT also. Remember, when we do this breast conservation surgery for non-invasive cancer, we call it BCS. But when we are planning a breast conservation surgery for invasive cancer, we call it BCT, and it is very simple. Try to understand. Now this is a female who wants a BCT to be done. So what is the classical thing? The only exception. So the relative, you can say this is a relative contraindication. Why? because if the lady goes into the third trimester, now she is already entering, so this is 12 and 12, 24, now she is already going into the third trimester. Now if she wants to plan for BCS, this trimester is actually the trimester. Why? Because now you will do surgery. Obviously whenever we do surgery, we wait for at least 6 to 8 weeks for the wound to heal completely, and then we can plan out the, you can say, post surgery management. So if she wants, so let us see how will you manage this patient. What are the options? Advise MRM for this, advise MRM to her in this trimester. Obviously this should have been the best option, this should have been the best option, but try to understand the lady insists on going for BCS. So wide local excision now followed by radiotherapy after the delivery, wide local excision in the third trimester followed by radiotherapy after the delivery, and NACT in this trimester. Try to understand, this is a case of LABC. This is not a simple case, this is LABC. What is LABC? Locally advanced breast cancer. So when we talk about locally advanced breast cancer, what are these locally advanced breast cancer? Remember T4N0M0, T3N1M0. So this patient, this lady qualifies into this group, and this is what is very, very, very important. Or it could be any T with N ranging from N2 to N3 M0. So if you see, she is anywhere qualifying for LABC, and whenever we have a patient of LABCs, we have to go for NACT. So what I will go for, I will advise her to take NACT in this case, and remember, she is not a candidate for breast conservation therapy or surgery. Why? Because pre-NACT staging is LABC, and for LABCs generally we don't prefer or recommend to go for the BCS. However, if still she is insisting on that post NACT, there is a, you can say, there is an option that you might advise, but this is not documented. The literature says that if it is a LABC, you have to manage this patient with MRM. So obviously this is not an option for her. The correct answer in this case should be 4. This is the best management for her. Let us move forward. So surgery, when we talk about, it should be MRM in this case. Now a 16-year-old girl presented to OPD with the following clinical picture. Which of the following is not true? If you see this, this is a normal breast, and here the breast is not developed but the nipple is developed. So this is a case of A Masia or A Masia. This is what is very, very, very simple. Let us try to understand the options. This is due to the failure of memory crest development. Try to understand, if the memory crest development is failed, this will never be taken as there will be athelia also. Why? Because do you know, there is mesenchymal proliferation, and when there is mesenchymal proliferation, then only, so at the time of birth the nipples are not there, it is the memory pit. So during the, you can say, formation of the mesenchymal tissue, the nipple is created. So option 1 is absolutely wrong. Why? Because nipple is there. So mesenchymal proliferation is not there, so nipple will also be not there. It can be associated with Turner syndrome. So let us see which of the following, let us understand which of the following is not true. Let us understand this. So this is due to failure of memory crest development. It can be associated with Turner syndrome. This disorder is called Masia. So this is true. This is true. This is due to the failure of memory pit. Students, if I have already told you, if memory pit is not developed, the nipple will not be there. Is that clear or no? So option C is far, far, far incorrect than option A. So I will take option C as the answer. I have already told you in MCQ there are 2-3 options which go very close, So let us move forward. Next is a patient presented to the burns emergency with a history of firecracker injury. So that's a what kind? That's a combustible substance. So that's a flash burn. So this is a case of flash burn with the burn seen on the hands and torso. Which of the following is used to assess the burn wound? Students, this question is a very, very, very easy question, but many people think that learn and broader chart should be the answer. Actually, what I will say, even though the option is giving in learn and broader chart, this is incorrectly because we have already corrected this. The answer for this is Wallace rule. Remember, despite the fact that learn and broader chart is most accurate, why? Because each and every part is calculated separately. This is not the recommendation. Why? Because the purpose of calculating the burn surface area is to start the fluid, and learn and broader chart is a complex chart which many of the surgeons are not able to recall at the time of trauma or at the time of need, and that is why we only believe in two charts. So Wallace rule, option C, is far better than option B. This is what is very important. So the ideal you can say charting may be learn and broader chart, but the principle behind calculating is not to file an autopsy reports to start the fluid management, and that is what is the reason why Wallace rule of 9 is the rule that we actually use here. Let us quickly move forward and let us see this. A 30-year-old patient complained with chronic diarrhea with intermittent colicky pain. The patient was evaluated and planned for laparoscopy. Which of the following is not true? So can you see the fat stranding, or you can say fat crepitation over the mesentery, and this is what is very important. So chronic diarrhea with intermittent colicky pain, this is the classical IBS, and inflammatory bowel disease when we talk about, or inflammatory, the patient had IBS like symptoms, but this is due to inflammatory bowel disease, and this is a classical Crohn. So fat creeping, the fat creeping of the mesentery is what we see in the image, and this is what is very important. So the option is, which of the following is not true? Which of the following? The skip lesions are present in Crohn's. Yes. The inflammation is submucosal. No, students, it is entire thickness is involved. So option B is actually false. Granulomas are present, but these granulomas are non-craziating. So this is also true. This is what is. So we have Vignettes classification, Montreal classification for the classification of Crohn's. So this is what is very simple. We have A, B, and C. It's easy. The next question that we are seeing is a newborn presenting to you. I'll cover the clefts. I'll cover the clefts also, and I'll cover the IBD, inflammatory bowel diseases, in the surgery section in the routine lectures. So discussing this today, it's not you can say possible. A newborn with the condition shown. So what are you seeing here? This is a cleft. This is a cleft lip, and do you know this cleft lip is going into the nasal cavity? So this is what type of cleft lip? This is a complete cleft lip. This is what is very important. So what is a complete cleft versus incomplete cleft lip? Cleft lip which is not going into the nasal cavity, that is incomplete cleft lip. A cleft which is communicating with the nasal cavity, that is what is known as the complete cleft lip. Most of the time this is actually the entire, you can say, primary palate which is damaged here. That is what is the complete versus incomplete. So this is a complete cleft. Which of the following classification is used to? So Vander Mullerian, Views, Leafort, and Neer. Remember the ideal classification for cleft lip, for the cleft lips and palate, we have the Views classification. When we talk about Views, we have 4 standard grading. What is the 4 standard grading? Basically there are 3. Let us see the 4th one also. So it is the cleft. Views 1 is a cleft of the secondary palate. This is what is very important. So cleft of the soft palate, basically soft palate is a part of secondary palate. So cleft or Views 2 is the cleft of the soft palate extending up to the hard palate, but remember, hard palate is having 2 parts: the primary cleft, the primary hard palate, and the secondary hard palate. There are 2 parts of the hard palate. Try to understand the part of the hard palate anterior to the incisive foramen is considered to be the primary portion of the hard palate. So the hard palate, the portion anterior to the incisive foramen also includes the gingival sulcus, the lip. So all these are included in this. So if it is involving the cleft of the hard palate, that is the primary palate, this is what is known as the views 3. And what is views 4? It is submucosal cleft. What do you mean by submucosal cleft? The muscular clefting is there, but the mucosa above that is intact, and this is what is known as submucosal. This is what is very important. So this is a very common system. I have written soft palate, hard palate, up to the incisive foramen, complete unilateral, and type 4 is type 4 is complete bilateral cleft of both the sides. The submucosal cleft is type 5 basically. It is not taken in the standard views classification, but cleft of the submucosa is also very important. Next is, let us try to understand a patient 34-year-old with complaints of severe epigastric pain radiating to back. So pain severely infecting the epigastrium radiating back. So that means something from the retroperitoneal origin is there. Amylase and lipase are elevated. Now you are handling a patient of what? Pancreatitis, which is not a risk factor for this. So alcohol, trauma, primary hyper. Students, this islet cell hyperplasia which is seen in nesidoblastoma or nesidoblastosis, this is not a part of, you can say, chronic, acute or chronic pancreatitis. So remember, this is not. So let us try to understand what are the risk factors for pancreatitis. Let us quickly see them also. They are very simple to understand. So when we talk about the pancreatitis, the risk factors for acute pancreatitis versus the risk factors for chronic pancreatitis. So when we talk about the risk factors for acute pancreatitis, what are these risk factors? You know, they may be metabolic, they may be mechanical, or the third category is others. When we talk about the metabolic, you know, it is either due to alcohol. The second is, it may be due to toxins or infections. It may be due to cassava or tapioca, because the cyanide present there might be damaging. The fourth is, it may be due to hypertriglyceridemia. So hypertriglyceridemia. Then hypercalcemia is a risk factor. And there may be certain drugs like valproate, methylsergide, which might cause. When we talk about the mechanical, when we talk about acute pancreatitis, it is mostly due to the mechanical causes. And the most important, the most common mechanical cause is gallstones. So gallstone pancreatitis is a known entity. Then secondly is ERCP. So when you are doing a sphincterotomy, you should be doing at 11 o'clock position for the CBD, but many a times there may be a thermal damage at 4 o'clock also, and main pancreatic duct is damaged. So that is what is ERCP induced pancreatitis. Do you know what is the criteria for ERCP induced pancreatitis? Fresh elevation of amylase lipase post ERCP procedure. This is what is very important. So new onset of pancreatitis, new onset of acute pancreatitis like symptoms, or worsening of the previous symptoms within 24 hours. This is important. The third is, it may be due to the annular pancreas. Or students, it may be due to pancreas divisum also. So pancreas divisum, annular pancreas, they are the classical risk factors. It may be due to sphincter of Oddi dysfunction also, When we talk about the others as the cause of acute pancreatitis, what are they, students? Cardiopulmonary bypass. So we have cardiopulmonary bypass. This is one. Do you know we have something which is known as polyarteritis nodosa. Then you may have heard of mumps orchitis, mumps pancreatitis, mumps parotitis. Yes, we have that. Cytomegalovirus, Coxsackie virus, all these things, they are the risk factor for acute pancreatitis. Always remember, when we talk about the risk factors for chronic pancreatitis, we have something which is known as Tiger O classification. So what is that Tiger O classification? Let us try to quickly understand that Tiger O classification also. So T in this Tiger stands for toxin, I for idiopathic, G for genetic, A for you can say autoimmune, R for recurrent conditions, and O for obstructive conditions. So when we talk about the toxins, what are the classical toxins that we have? You know, the most common cause of chronic pancreatitis is nothing but alcohol. Then we have the smoking or tobacco as a risk factor. You should also know that we have hyperparathyroidism. Now why hyperparathyroidism is so lethal here? Because hyperparathyroidism causes hypercalcemia. Same is the reason with CRF, because CRF causes secondary hyperparathyroidism resulting in hypercalcemia. Then we have topical, so topical pancreatitis, and this is always due to dietary agents like cassava, and then we can have chronic infections, the reason behind them. So this is all about, this is about the toxins. Then we have I, you know, I is idiopathic, and when we talk about the G, what is G, students? Genetics. Now when we're talking about the genetic causes of chronic pancreatitis, so let us try to understand. We have something which is known as PRES1. So we have PRES1, we have PRES2. So PRES1 and PRES2. What is PRES1? This is cationic trypsinogen. So cationic trypsinogen gene. And then what is PRES2? This is anionic trypsinogen. So always remember this trypsinogens, or you can say cationic or anionic trypsinogen, both are associated with hereditary pancreatitis, and this is what is very important. So we have PRES1, we have PRES2. The another one we have is a classical SPINK mutation. So where is the SPINK mutation associated with? This is associated with tropical pancreatitis. Do you know what is the reason for SPINK mutation associated? It is nothing but the patients who have SPINK mutation, they have a higher incidence of recurrent acute pancreatitis, and because of this intraacinar activation of trypsinogen into trypsin happens, and which causes proteolysis of the pancreas and damage to the pancreatic duct, and thus escape of the pancreatic juice, and then you know the damage is going to happen. Then students, you may have it due to CFTR gene mutation, which is associated with cystic fibrosis. So this was TIG now. So we have A also. A, you know, the Tiger A. So A stands for autoimmune causes. So IgG4 type of pancreatitis. You should know that IgG4 is of two types. Type 1 is associated with pancreatic and peripancreatic, or different organs are involved. When we talk about type 2, it is only involving the pancreas. Then we have R. When we talk about R, what is so special about R, students? It is recurrent episodes of what? Acute or recurrent episodes of severe pancreatitis. This is what is very important. I hope you know severe pancreatitis is a pancreatitis where you have infected pancreatic or peripancreatic complication, and along with that, or you can say you have persistent organ failure. If both are present, that is persistent organ failure is also there, and there are infected pancreatic complication. Now this will be known as critical pancreatitis. You can check out my lectures, and there I've described about the modified Atlanta's classification, where there is grading of the pancreatitis also. And then students, we have O. So what are these O for? These O are for the obstructive type or obstruction. So what are the reasons for the obstruction? It's very simple. It could be due to the pancreatic duct stones, it could be due to the strictures, it could be due to ERCP, it could be due to a rim of tissue around the pancreas, that is annular pancreas, it could be due to the pancreas not fusing, so pancreas divisum, and it could be due to SOD. What is SOD? Sphincter of Oddi dysfunction, and I hope you know that it is pancreatic type, or it is biliary type, or it may be mixed type also. We have a classical classification which I have taught in class, Milwaukee's classification, where pancreatic duct symptoms might be there. So if it is a pancreatic SOD where the sphincter pancreaticus is not relaxing, you will have a dilated pancreatic duct, elevated amylase lipase, and pancreatitis like pain. This is type 1. And do you know, when we go for a scintigraphy, we also measure the transit time of the pancreatic juice if it is found to be more than 6 to 10 minutes. In case of biliary SOD, this is more than 40 to 45 minutes. So this is type 1 pancreatic SOD. Type 2 is where you have pancreatitis like symptom plus one of the features like dilated duct also is there, or maybe the enzymes are elevated. If there are no other symptoms except the pancreatitis like pain but amylase lipase and the duct diameter is normal, this is what is a type 3 pancreatic SORD. This same pattern is followed in the biliary SORD also. Like what is that? Dilated CBD, then we have biliary type of pain. The third is the enzymes like alkaline phosphatase, or you have obstructive jaundice. The next is the biliary transit time. This is optional, is more than 40-45 minutes. So same, if the biliary type of pain is there and any one of the other features is there, that's a type 2. If nothing is there, only biliary pain is there, that's a type 3 biliary SORD. So that was Milwaukee's classification. How do you confirm the sphincter of Oddi dysfunction? Answer is ERCP manometry. And remember, the resting pressure which used to be around 10 to 12 mmHg, if it is elevated to an extent of 40 to 45 mmHg, that is what? Pancreatic duct or CBD both duct stenting with a sphincterotomy. This is what is the management of sphincter of Oddi dysfunction. So this was the today's session of test and discussion based discussion. Tomorrow again we shall resume. So every day we will be having a short discussion of the paper that you have given, and every week you will have paper. So I hope you are enjoying learning with Surgery Dada, and Surgery Dada is always committed to help the students. So what are you waiting for? If you are still not joined Surgery Dada, do join and do recommend your near and dear ones for the club, that is exclusive surgery club, that is Surgery Dada.